Dr. Mattis, tell me about a time when using NuMatuSeal would have been incredibly beneficial to your practice and your current casework.
Every day, every day. Uh, we recognize that when we do bronchoscopies, specifically flexible bronchoscopies, we occasionally have difficulties advancing our tubes through our existing airway devices. That creates, because of the nature of the existing devices and our scopes, we have a reduction in appropriate cross-sectional areas for optimizing ventilation and oxygenation.
Mm-hmm.
And in patients that we deal with that are already compromised from a respiratory function standpoint, that are on a ventilator, and now we introduce an obstructive foreign body, which is our bronchoscope,
Mm-hmm.
into that conduit, that airway channel for oxygenating and ventilating our patients, that disrupts optimal ventilation, optimal oxygenation, and what happens? We often have to remove our scopes, wait for anesthesia to give us the green light to reintroduce our scopes and continue
Mm-hmm.
our procedures. Um, and again, if we are in the middle of cases that become challenged by complications, even minor bleeds that may obstruct more distal airways, and we have the recruitment or loss of functional aerating, uh, functional lung units.
Mm-hmm.
In those circumstances, we want to have an optimal passage of oxygen and ability to ventilate our patients. So with flexible bronchoscopy, I see it almost every day. Um, with rigid bronchoscopy, as I said before, there is no existing device that optimizes that seal and helps us to better get through our rigid bronchoscopy procedures, which are usually, when we're doing therapeutic bronchoscopies, it
Mm-hmm.
can get ugly. We can have bleeding, we can have partial transient obstructions of the airways, we can have loss of appropriate oxygenation, patients become hypoxic, that may cause some hemodynamic instability. And these patients, again, they are very sick.
Yep.
They're very ill with poor lung reserves, and now we're challenged to not only get them through their acute challenges, their acute illness that brought them in to do the bronchoscopy, but now we also have problems in the moment from complications during our procedures. So we really have to find a way to support these rigid bronchoscopy procedures as well that are high risk and potentially can be even more difficult than anticipated. And so we want to have a stable, optimized platform for really allowing the proceduralist to focus on doing the procedure and not having to worry about how to improve the patient's status throughout the procedure. And this brings me to another point. We're a team. The interventional pulmonologist, the bronchoscopist, is not working alone. We're also working with
Yep.
anesthesia providers. And the anesthesia providers become very uncomfortable when there are devices, within their airway devices. And depending on where you work, institutions with large anesthesia provider groups, and they rotate, they're not dedicated groups, they rotate through the rooms maybe once a week, once a month.
Mm-hmm.
We see these procedures every day. They don't necessarily see it every day. So their comfort level is all over the chart.
Right.
And because of that, we want to be able to take that pressure and that concern off of them so that we, as our proceduralists, can actually focus on our procedures and not have to be distracted by their discomfort levels, which happens.
Mm-hmm.
It's a necessary situation that is not fully necessary per se, in that if we have a better solution, we can probably minimize those occurrences wherein the team is uncomfortable and we have a relatively unstable patient who is acutely ill during their procedure.